Good afternoon, everyone. Thank you for joining us. We'll get started in just a couple minutes. Good afternoon, everybody. Thank you for joining us. We'll get started in just 1 minute. All right. Thanks, everyone, for joining us today. We're happy to see you're all here. I'll turn it over to Kamar McIntosh, who will start the intro for us.
Welcome, everyone. So let's just jump straight into it. First slide, please. So this is our final webinar for our series of 4 webinars dedicated to youth suicide prevention initiatives. And for today's agenda, we will frame the webinars within the broader NYC Health Department context, provide an overview of previous webinars, presenter introductions, housekeeping, and the presentation. The health department aims to reduce suicide deaths and suicide-related behaviors among New Yorkers, with a focus on youth of color. To achieve this aim, NYC's health department will facilitate innovative suicide prevention pilots that serve youth and young adults of color. We'll also oversee Caring Transitions, which is a continuum of care pilot, collaboratively created by the health department, health and hospitals, and the mayor's office of equity to reduce suicide-related readmissions to emergency departments for youth in Queens and the Bronx, ages 5 to 17 years old. Next slide, please. The health department suicide prevention initiatives are being executed through interdisciplinary partnerships with community-based organizations, researchers, designers, and medical institutions across NYC to provide enhanced monitoring of suicide as an urgent public health issue, to increase and diversify suicide prevention services for youth and their support networks, and finally, to expand efforts to mitigate the socio-environmental risk factors for suicide through interdisciplinary strategies. Next slide, please. So, just as an overview for the webinars, the Health Department is investing in action-oriented research and capacity-building efforts intended to raise awareness about suicide risk and protective factors for New York City's BIPOC youth. This is why we facilitated a series of 4 webinars dedicated to this topic. And the other webinars that came before this one discussed trends in suicide among youth of color, covered systemic racism, and explored risk and protective factors for suicide among youth of color. And we also reviewed cultural humility principles for diverse community work. Now I'll pass it over to my colleague, Claire Ockburn.
Thanks, Kumar. Good afternoon, everyone. My name is Claire Ogburn, and I'm the Data and Program Coordinator for Suicide Prevention Initiatives at the New York City Health Department. And I'll start by telling you a bit about today's presenters. Our first presenter is Dr. Erin Godfrey. Dr. Godfrey is Associate Professor of Applied Psychology at New York University, and she is the Director of NYU's Institute of Human Development and Social Change. And next up, we have Dr. Shabnam Javdani. Dr. Javdani is Associate Professor of Applied Psychology at New York University, and she directs the NYU Prison Education Program, which expands access to higher education among incarcerated students. And finally, we have Dr. Jocelyn Meza. Dr. Meza is Assistant Professor in Residence in the Department of Psychiatry and Biobehavioral Sciences at UCLA, and she's the Associate Director of the Youth Stress and Mood Program and the Principal Investigator of the Health Equity and Access Research and Treatment Lab, or the HEART Lab, also at UCLA. Thank you all for joining us today. And before we get started, I'll go over some housekeeping items. So first, as Kumar stated, this is the final part in a 4-part webinar series. So after this webinar ends, we'll send out all 4 recordings and the slide decks. Next, our presenters have done their best to use sensitive language in this presentation, but the topic is tough and could be triggering. So we'll share resources about 988, the Suicide and Crisis Hotline, in the chat, and I'll also put my email in the chat, and you can reach out to me if you would like additional resources. The chat box is open and we welcome your comments and reflections there. And if you have questions for the presenters, you can use the Q&A function to submit those. And finally, we'll send a quick survey at the end of this presentation, and it would be really great if you all share your feedback with us so we can take it into account for future presentations. And that's all. So I'm going to turn it over to Dr. Meza, who will begin the presentation.
There we go. Good afternoon, everyone, and welcome to our 4th and final webinar of this series. Shout out to the Puerto Rican Family Institute. I see that there's a lot of you represented here, so I wanted to give you all a shout out. And this webinar, I would say, is my favorite webinar of the series, because as a clinical psychologist, today we really get to focus on the clinical implications of the conversation that we've been having, for these last couple of months. How do we address structural issues into the work of suicide, especially for youth of color? So really our goal after today's session is that by the end, you should all have a better idea of what are some of the current treatment gaps that are currently impacting suicide rates for youth of color. In the previous sessions, we focused more on structural issues, risk and protective factors from a research perspective. Now we really want to take a more focused approach on what are the access barriers to clinical care. We also hope that by the end of this conversation or this webinar, you will be able to describe and understand our current evidence-based treatment for suicide, and to also highlight at least one social cultural issue that's impacting suicide prevention treatment. And hopefully by the end, you will all be able to not just articulate treatment components for suicide for youth of color, but also integrate them into your own practice. I see in the chat that a lot of you are clinicians that are working with families. So hopefully you will be able to use some of the skills or some of the resources that we will be sharing today. To get us started, I want us to have this reflective approach and to really think about who we are in our identity and how our position contributes to the clinical services that we provide. I always do this activity in my clinic with all the trainees that we have at the UCLA internship or our postdoctoral program. And it's always really interesting to hear how people's experiences and life histories impact their trajectories to their profession. And that's a really key component in all of you providing cultural safety or providing equitable care for our families, because we are taking some time to really reflect on not just ourselves and our identity, but how the context around us is impacting our work. So if you are sitting down on a desk or whatever it is that you are, if you can take out a piece of paper, or if you have your laptop, or if you have your phone on the notes section, I really want you to answer some of these questions truthfully. If some of you feel comfortable, if you can share, I'm going to open the chat because I really want to see what you all have to say. And I want you to write some reflections on the following questions. So I already read the first one on how does your identity, this includes gender identity, your ethnicity, your language, your culture, your immigration status, and your positionality. How do those contribute to the clinical services? I also see that some of you are research associates, or your research provided. How do these things contribute to both of those things? I also want you to think, how does the context, either where you conduct your research or where you're doing your clinical work, how does that shape the interactions that you may have with your patients? Are you in a setting that is, easily accessible to families? Are you in a context where you feel that may be further apart from some of the families that you want to reach? And this is my favorite one. How did I decide to become a mental health professional or a mental health scientist, researcher? You can fill in the blank. How is it that you made that decision, and when? Where were you at developmentally or in your life when you made this decision? For a lot of people, it was at a moment where they may have had lived experiences, or where they had an interaction with someone that really shaped them in their career decisions. Number 5, for whom are we providing care for? In favor of what? To what end? This may be something that you need to collectively answer as a group if you're part of a larger clinic. How are our unique perspective influencing our clinical interactions? Think about how you show up to work every day, the space that you're in. How does your therapy room look like? And most importantly, I want you to think about what power dynamics may be at play. Now, this last one takes a lot of work to really reflect on, to think about how our own maybe biases may be playing a role, or how maybe structural issues where we're embedded in may be contributing to power dynamics that may be at play. So if you can just take a few seconds to write those things down or reflect. And I see some people are sharing in the chat that some of you decided to pursue a career in mental health because you wanted to help people. That was at the core of this decision. Some people are sharing that their background as an immigrant allows them to bring this cultural competence to the interactions that they provide, right? You have that lived experience with being part of an immigrant family. Some of you, oh my God, these are so good. Some of you are sharing how there's a common thread here. A lot of you wanted to help people, and that was at the core of why you wanted to become a mental health professional. And as you are writing these things, think about, have you achieved that goal? Are you helping people? How are you achieving that goal? I wish we had more time to really do this together as a group. This always leads to a lot of reflection and change that is required to provide equitable care. But hopefully I ignited some conversations and some reflection for all of you to continue. You will have these slides So if you want to bring this back to your work setting and have it with everyone, this conversation, I think it could really start an important conversation on how you can improve your care for more diverse families. And thank you to everyone in the chat that shared a lot of your experiences. Alrighty, so the reason why I had you all think about your positionality and to reflect on power dynamics is really because our patients really have to go through a long journey to get into care. A lot of people think that you wake up one day and you realize that you have symptoms of depression, and then the next day you go into treatment. And although that sounds great, that's not always the case. There's actually many, many steps to get into care. And within each step, there are more barriers. And in particular for suicide care. And we created this heuristic to really walk you through the unique barriers to care for families of color seeking suicide care in particular. And that step number one is proper problem recognition. What is that really? It's not just the patient realizing that something is impacting them and their daily living or their life, but it's also us as clinicians recognizing that there's a problem and seeing them how they're manifesting their own problems. What do I mean here? Some of our screeners, unfortunately, are not capturing the distress from our families or our patients. So we have to think about how can we as clinicians recognize how problems show up in different communities. And that's going to be a thread of conversation that we're going to have a little bit later in terms of how do we see the problem from different perspectives, not just from a page Q9 item that oftentimes misses a lot of our participants. That's the first step, right? Like recognizing that there is some need or that there's a problem that needs to be addressed. The second step is really to make the decision that we need to seek help. Here is where we see that there's a lot of gaps in knowledge. There is oftentimes a lot of misdiagnoses that lead to different care. And then the search for care, I think it's probably one of the most difficult challenges with decision to seek help. A lot of families tell me, like, is there a specific website where I'm supposed to look what the specific care is for my child? How do I know it's actually true? There's a lot of misinformation. So this barrier here does create a lot of roadblocks for families. And it's tied to step number 3, which is after you've made the decision to seek care, you also need to make a selection in terms of what treatment you want, right? Do I want CBT that's trauma-informed? Do I want dialectical behavior therapy? Do I want interpersonal therapy? It can become very, very challenging for families to really understand what service is the best for my family or my kid. It becomes even a bigger challenge when we think about the kids that are embedded in other services or in other systems like the child welfare system or juvenile legal system, because those systems may be providing additional care that may not be addressing, in this case, their suicidality. So how do we work collaboratively with other systems of care so that we're integrating services for families? And then if we move furthest along to the last stage or the last step, is how do we really engage our families after they've gone through all of this odyssey to get into our clinic, to actually walk into treatment? How do we keep them engaged and not lose them, right? And I think that's where most of us are really working hard to keep our families in care and engaging them in care. In a little bit, I'm going to talk about how for suicide in particular, DBT, which is the only well-established treatment, has created a lot of access issues for families of color. For one, because DBT clinics are not as widespread. DBT is a pretty long treatment. It has a long treatment course. Most of them are 6 months. And there aren't a lot of clinicians of color that are trained in DBT. So how do we disrupt some of those issues that are impacting our care? So now that we've kind of done a broad overview of what are the unique barriers to care to suicide, I want us to also really think about how do we disrupt them, right? Because my goal is to not just deliver the bad news or talk about what are some of the issues, but how to actually provide solutions and move things forward, right? Because I think that's why all of us are here today, because we're generally so invested in making suicide prevention more equitable for our families and communities. So I'm going to briefly talk about some solutions that I published with some colleagues that have different training backgrounds, one of them being a psychiatrist. And we really came together to think about what do we need, what do we think is needed to advance our science and in suicide. First, and I think most importantly, is that we need to see our patients and or research participants through the context that they live in, not from an individualized perspective. We need to take into consideration the entire context, or all the different contexts in which our participants are embedded in, or our patients. And importantly, to identify culturally relevant risk and protective factors. Why is that important? This is really important because our culturally or social culturally relevant risk and protective factors should really be guiding your treatment planning. If that is currently not the case, then that's something that needs to change, because we can no longer continue to dismiss that cultural risk and protective factors are so important in not only engaging our families more, but making our treatments more effective. And if you really think about it, our cultural context is such an integral part to a lot of the families that we work with, but we rarely talk about it in the clinical setting. Hopefully that's not the case for everyone. Some of you may already be integrating this into practice, and we really want to make more standardized approaches to embed these culturally relevant risk and protective factors into our work. And in a little bit, I'm going to share a little bit some more specific culturally relevant risk and protective factors, or you can also watch webinar 2, where we really just focused, that was the whole topic of webinar 2, was identifying culturally relevant risk and protective factors that should be integrated into your care, into your treatment planning. That's the first step. The second step is to also expand our screening to consider racism, discrimination, and acculturation. For those of you that use the NIH Ask Toolbox, it's a great, I would say, clinical tool to help us assess risk for suicide. And it also has all of these different questions that you want to follow up on, like perceived social support, conflict with parent or with peers. But one of the things that it neglects to do or fails to do is to really examine or screen experiences of discrimination or acculturation. And the reason why I am really making this point, and I'm going to continue to make it throughout this conversation, is because both clinical and research evidence suggest that suicide for youth of color is really impacted by their experiences of oppression, experiences of marginalization. And we know that experiences of discrimination and acculturative stress, acculturation gaps with their parents are really disruptive to their identities. And it also impacts their perceived sense of belongingness to society. So because it's so key to these constructs that we know are central to suicide, why aren't we addressing this clinically? Why aren't we screening for discrimination as part of our risk assessment? And how can we do it in a way that is feasible and that will lead to actual change? One thing that we've done in our inpatient unit at UCLA is every time that we do have a patient that is admitted into our inpatient services, we screen for discrimination. And not only are we screening, but we're also trying to understand how can we integrate services in this setting to address that experience of discrimination. If people have some ideas that they like to share in terms of screening for discrimination, please feel free to add it to the chat. Number 3, investing in cultural adaptation of existing evidence-based protocols, which the team here has already done and invested in cultural adaptation treatments in the New York area. So far, they have been 2 large randomized controlled trials that have really taken on that initiative of culturally adapting evidence-based care. And one of the key ingredients of suicide prevention is the use of safety planning. However, our safety planning strategies have remained pretty stable or the same since the development of the safety plan. So how do we adapt a key treatment strategy like a safety plan to really integrate or take into consideration the context? So I'm going to give some very concrete ways in which you all can adapt your safety planning strategies to make it more inclusive of different experiences or of different contexts that you're seeing can experience. I'm also going to, in a little bit, talk a little bit more about dialectical behavior therapy and why it's the only level 1 established treatment. But there have been several adaptations to this treatment. One of them was done a few years ago in a different country. So what was done in Spain is that they adapted dialectical behavior therapy in a pragmatic approach to be delivered in a community setting. I've included the citation here if people want to have more information about this trial. And I'm also going to talk about the work of Jovanska Duarte Velez, who has really led one of the only treatment trials to improve suicide outcomes in Latino youth. So I'm going to be talking about her work a little bit more as we move along. But we really do need to invest in more culturally adapted treatments of evidence-based care. I think we've already established what treatments work. Now what we need to do is how do we make them work for the families that weren't included in those trials? How do we make it work for the other families that are presenting to our clinic? That's the key next step here. Okay, solution number 4. How do we not just identify structural barriers, which I talked about in that figure where I talked about the different access barriers, but how do we as clinicians or as a clinic, how do we think about disruptive and innovative ways of delivery, right? So can we think about, I think a lot of you are already doing this, but telehealth delivery. How can we reach more people that are in more remote areas through our telehealth or digital platforms? Can we think about different people that can deliver these interventions? Does it just have to be a psychologist? Can it be a community health professional? Can it be families that we're working with and training them and giving them the capacity to support their community members? So we call these promotoras. And can we embed some of the work that we're doing within larger settings? This could be schools. Can you partner with school settings to deliver after school curriculum that focuses on resilience or focuses on coping strategies? So really think innovatively and disruptively here on how you can provide the services that you do in different care settings. As an example, one thing that I can share is last year, I partnered with a local library, and I worked with the librarian to help me recruit families so that I could do an after-school program for children ages 8 to 12 on building resilience and how they can use their what we call cultural assets to improve their mental health. We had over 70 families show up to the library that they were interested in this service. So I think that's just a testament to how different settings may feel more welcoming to our families, how different settings may allow us to reach a larger audience, right? So if people have ideas, put in the chat how you can think about different delivery strategies. Think about who you can partner with in your community to expand your access. So I see some people, if you can share your ideas or some other possible solutions that can get at these two barriers of cost and time, which is oftentimes, I would say, the main barriers to care for a lot of our families. If you have some ideas on some solutions that I haven't already mentioned, please put them in the chat so that we can maybe start working together on thinking about different delivery strategies. Okay. Solution number 5, or possible solution number 5, is how can we ensure inclusivity of diverse samples and analyses of race and ethnicity in large randomized controlled trials? The issue with a lot of the work that has been done to date is that families, mainly Native American, Black, and Latinx families, are not intentionally recruited into large randomized controlled trials. So if they're being left out of these treatment strategies, it is really hard for us to make the assumptions that these treatments are going to work equally as well for them, right? They may, they might not. And the only way for us to figure it out is if we have large enough research samples that can allow us to test for these differences. And that has not been the case in the last 20 years of suicide intervention trials, with a few exceptions, which I will share in a little bit. There's a few exceptions of 3 trials. So one of the things that we have started to do in our work is we've started to partner with families or local clinics so that they can help us recruit families. And I think one of the narratives that I've been hearing from the families that I work with is they have this mistrust with the research process. And once you sit down to have a conversation in what the research process really is, a lot of these families are really open and want to participate because they do want to advance the science. But I think we just need to go the extra mile of having these open conversations with our community members and being really mindful how we are talking about research. So one of the things that worked effectively for me is when I was talking to the 70 families that showed up to the library to receive care, I gave them the option to participate in research. And I realized that the direct translation of the word research sounds very scary in Spanish. However, when I explained that it was, we weren't doing this experiment, that's the word I was looking for. In Spanish, it sounds like it's an experiment. Once I discussed with families that we weren't experimenting anything on their kids, they were more open to being part of this process. They were even more willing to participate when I shared the research process with them, meaning they were co-authors of the publications, they were part of the IRB, they helped, create some of the assessment tools that we were creating. So they were really integrated as part of the process. Once they were part of that research process, they were able to disseminate to other families the work that we were doing, and we got even more families to participate. So just thinking about different community-based strategies that can empower the community so that they can be part of the research process, which they haven't been for a really long time, at least for suicide treatment trials. And our last strategy, which I think we can dedicate a whole webinar in talking about, how do you actually train trainees or the coming workforce in delivering culturally competent and anti-racist care? Because that sounds all good and dandy, right? Like, oh, anti-racist care or culturally competent care. But how do you actually do that? How do you actually get to that point of where you're delivering this care? We're going to talk a little bit about this, but I really do think this could be its own training on how do we actually start helping provide anti-racist care. One of the strategies that we have been discussing in my lab is how do we train clinical supervisors to focus on structures when they're talking about suicide prevention with their trainees. So that's one upstream effort that we've been discussing, is working with current clinical supervisors as people that can deliver this training. Okay, so now that you have some ideas on some possible solutions that can help us make our evidence-based for suicide more equitable, I want to share a little bit about the history, or what we know in terms of what has been done to improve suicide, especially youth suicide. Most of the work to date has focused on adults, and very, very little has focused on children, right? So children ages 5 to 12, who for the first time in history, suicide is the 10th leading cause of death for children. It used to never be on the top 10 leading causes of death, and now for the first time it is. So there is even more work that we need to do with children. But with adolescents and young adults, what has really been done? We know from an excellent article that I recommend everybody read by Glenn et al. 2019, they reviewed 26 treatment trials that have been tested, rigorously tested for their effectiveness on suicide. And what I mean by effectiveness for suicide is, do they actually work in reducing risk for suicide? And what they found across these 26 interventions was that only one type of treatment has enough support to be categorized as a level 1 well-established treatment. What that means is that there are different trials that are testing the efficacy for DBT that all converge to suggest that it actually is efficacious and that it works for reducing self-harm risk or suicide risk. And as I've already mentioned, the challenge with DBT is that it's time consuming. It takes about 6 months for families to complete a cycle of DBT. Unfortunately, a lot of the families that we want to serve don't have that time or money to be able to do that. So what we did in a study is we looked at all of the interventions that have been published to date, and we coded all of their treatment trials. The reason why is because there is what we call a 17-year odyssey from when there is a research study and when it gets implemented into the community. We do not have 17 years to wait to get all of these services or treatments into the community. So what we did is, to bridge this gap, we looked at all of the different studies that have tested a specific manualized treatment. And what we did is this very specific type of analysis, is we looked at a common elements approach. And what this approach does is it allows you to integrate all of the manualized treatments to date on a very specific outcome. In this case is suicide. And what we did is we coded all of their treatment targets. I was very lucky that I got 100% of all of the treatment manuals for suicide. And what we did is we divided into 2 categories. Did they work or did they not work? For those that did work, what were the treatment elements? What were the treatment ingredients that they all had in common, so that we can deliver those in the community? I know we're a little bit short on time, so I'm going to skip a little bit on the strategy. This will be available to you. But what we found were that there were 2 key elements that stood out as being robust and common across all of the treatments that worked. And they weren't part of the treatments that didn't work. So for those clinicians in the audience, what do you think are those treatment ingredients that came up as treatment ingredients that were present in all of the trials that did work or that were efficacious? I'm wondering what people think are the key ingredients. I'll just wait like 10 seconds for people to put it in the chat. Aditi and Carolina are really great. Both of you actually got it correct. So building rapport was a key ingredient in all of the interventions that worked. The interventions that had some ways for the providers to actually build rapport into the treatment process, which sounds like, well, duh, but you would be surprised how some of the interventions didn't integrate this as a key component. So I'll share some of the results, which some of you already guessed correctly. In terms of format elements, there was one component that we found that was a key ingredient, and that was the family integration into the treatment process. The treatment trials that did not include family as part of the treatment process, they weren't as effective in reducing suicide risk. So there is something really important about integrating family sessions into the practice to reduce risk for suicide. One of the things that I thought was going to be significant, but wasn't, was phone coaching, right? Which is more DBT oriented, but phone coaching is this clinical approach and where the clinician is available during high risk moments for the family. So that didn't emerge as a key ingredient in effective treatment strategies. When we looked at content elements, there were two that I really want to point out here: safety planning and means safety. Those two key ingredients together seem to be the dynamic duo or the perfect combination for treatments that showed efficacy. And in a little bit, I'm going to talk about some key resources that I have found helpful for both means safety and safety planning. So those were the content elements that emerged as key ingredients. When we looked at the process, as some of you had already shared in the chat, this rapport building emerged as significant. Psychoeducation also emerged as a significant ingredient in treatments that work. And again, this will become available to all of you. There's also a JCAP podcast that is dedicated to this specific article. If my colleagues, Aaron or Shabnam, if you can put in the chat the link to the podcast that describes the study so that we can share it with participants. So I'm gonna move to the last slide here. So the point that I really want to make here is that I'm not against manualized evidence-based treatments. I think they're helpful when we are working with a particular clinical outcome. However, it does create a barrier for implementation in some routine clinical settings, especially in clinics that serve communities that have historically been underserved. So one strategy for us to overcome this barrier is to deliver treatment ingredients that we know work. From our analysis for interventions for suicide, we found that the integration of family, emphasizing the therapeutic alliance, and using an individualized case conceptualization to guide treatment were really key. In particular, to conduct lethal means restriction as part of the self-harm monitoring and as part of the safety plan is the point that I really want to make here. In community clinics and where resources are sparse, if we could at least provide lethal means restriction and safety planning, we can go a long way in providing these services. Okay, so I promised you all that I was going to share also some of the good news in terms of what has been done with culturally relevant, culturally responsive suicide intervention for BIPOC youth. There have been some really interesting publications. I really encourage you all to read this chapter that was recently published. And what Dr. Duarte Velez did in this chapter is they were able to classify all of the treatments that have been published to date. And what they did is they classified them into 3 categories. is this treatment intervention, is it specifically for a particular ethnocultural group? B, is not for a particular group, but it does pay some attention to cultural context. And C, this treatment trial is done without any discussion of ethnocultural context, but has some Latinx youth as part of their research participants. Sadly, they only found that 2 treatment interventions actually were classified as A, meaning that they were developed for a specific ethnocultural group. But out of those 2, only one of them focused on actual suicidal behaviors and not suicidal ideation. And that's the one that I'm going to share in my actual next slide. And that one is the social cognitive behavioral therapy for Latinx adolescents with suicidal behaviors. This was published a little bit over a year ago. And the second one is a group-based intervention that was specifically developed for Black youth. And I'm going to talk a little bit more about what made these interventions so effective and also so unique. And they have a lot of treatment components that I think we can borrow from to improve the care that we're providing. So we'll first start with the social cognitive behavioral therapy, which is the first psychosocial treatment for Latinx youth with positive evidence for reducing both internalizing like anxiety and depression, also reducing future suicide attempts in a randomized controlled trial, which is regarded as like the gold standard for testing the efficacy of an intervention. And although it had a lot of very similar skills as dialectical behavior therapy, like focusing on emotional regulation, activities for behavioral activation, how to have more effective communication with your peers and your parents through social interactions, I think the key ingredient that made it really effective for Latinx youth was part number 1, where it really focused on the adolescent identity and how adolescent identity was impacting their mental health, how adolescent identity was impacting their families. One of the things that they discuss as part of this crisis module is they talk about acculturation gaps with their parents. And then the parents are given strategies on how to parent a kid that is Latino but lives in the US, right? So these strategies can be really helpful when talking about Latino teens that are struggling as they're kind of developing their own racial and ethnic identity, and they may have some different cultural values than their parents. How do you consolidate that? How do you bring that into the treatment process? So I think that's what made this approach so effective. And it was also grounded in the social, ecological, developmental, and gender perspectives. They also had some conversations of gender identity and sexual identity, and how do you have those conversations with your parents? So that's why I highlighted that in red, because I think that was the key ingredient. And the second one that I talked about is the Adapted Coping with Stress course. So there's a few publications that I cited in the bottom if you want to read the whole article. This treatment strategy is a little bit different from the one that I just discussed that incorporates the parents and its individual therapy. This one is group-based care. So adolescents are given skills on how to cope with racial stress or with systemic racism. And the trials that have been conducted to date, not only do they show that it's feasible and that the teens really like the content and they find it helpful, it also shows that it reduces suicide ideation. So it's effective for suicide ideation. And I also highlighted the component that I think made it really helpful for the families is that they included a community-based participatory research approach, which means that they invited families and parents and teens to participate in the development of the actual treatment manual. So some examples of what the manual looks like is they would be shown a picture of a culturally or contextually relevant experience that Black youth experience, and then they would talk about ways of resisting or coping with situations like this. So this was just to give you an idea of how this intervention really addressed the context, and it gave adolescents skills on how to address these contexts. Okay, I'm gonna skip through this because I know we're a little bit short on time, but I really do want to bring this this new framework to people's attention, and this is the Structural Racism and Suicide Prevention Systems Framework, which was recently published by Dr. Kiera Alvarez and colleagues. And what I really like about this approach or framework to suicide is that not only does it highlight how the social cultural context impacts the continuity of care, but it also provides some strategies on how can we address systemic racism in the work of suicide. So I've actually, in this slide, and if you look all the way at the bottom, they talk about intrapersonal racism. And one of their strategies for a structural way to intervene or address this clinically is to target race-based stress and trauma and promote racial socialization, promote race-affirming and race-validating strategies into clinical care. So this is an example of the intervention that I just shared with you a few slides ago on the adapted coping with stress. So what I really want you all to think as you bring back some of these ideas to your clinical care is how can you actually target or address race-based stress into your care? Do you have any trainings that you can go to? Do you have any assessment strategies that you can integrate? Oh, it looks like I'm frozen. There we go. Okay, and I want to wrap up with this recent article that I was able to collaborate with a lot of people that have the shared interest in making suicide prevention more equitable. So we were able to publish some recommendations on how we can assess suicidal thoughts and behaviors in youth of color. Again, this article, we can share it with you, but I'm going to summarize it in some brief recommendations here. So this is a heuristic or a visual that really summarizes the whole article, but I'm going to walk you through our recommended approach for culturally responsive suicide risk assessment. First is how do we integrate the societal context? First is we need to address stigma. How do we design and order our assessment items to enhance rapport and likelihood of disclosure? And some of you in the chat shared, like building rapport with participants is so important. So how do we do that in our assessment procedures so that they're more likely disclose their actual suicide ideation. Acculturation. How can we assess acculturation level and heritage culture retention? How do we identify acculturation gaps between youth and their caregivers? There's actually some brief assessment questionnaires that you can integrate that cultural values, and you're able to see exactly where the youth and their parent deviate, because they might have some shared cultural values, but in some very specific, for example, need for autonomy is where they might be, they might have larger gaps. So how do you address that? For racism and discrimination, how can you assess for experiences of racism and discrimination, both in person and online and across different contexts? Like I said, if you can integrate the screening as part of your suicide risk assessment, not as an afterthought, that makes it easier for the participant, or it makes it more inclusive. Institutional context. So how can we make sure that we're also addressing healthcare and community infrastructure? So this means assessing available mental health crisis support resources. Are there support resources that are available in different languages? How can we share those resources with our families? Assessing other forms of mental health social support. So asking about families in which ways they have received info support in the past, and if that has helped, how can they continue accessing these, what we call informal support or social support in their community. Some of the families that I've worked with, they have said that having a curandera was really helpful in their mental health. So how do we integrate that as part of our care as well, and not dismiss it as, you know, not a helpful form of support? And importantly, how can we access and assess lethal means restriction? In a few slides, I'm going to share a website that allows you as a clinician to provide your families with a decision aid tool on how do they keep their kids safe, how to keep their home safe. And it also gives them a printout of strategies on lethal means restriction. And it's in both English and Spanish. So I'm going to share that in a little bit. Also contextualizing the teen and what other context they're in, like the neighborhood context, assessing experiences or exposure to neighborhood violence, whether it's in their neighborhood or in school. And then I'm going to move on to the next one, sorry, the family context, really assessing for culturally relevant family dynamics, experiences of intergenerational trauma, experiences of cultural differences or cultural gaps with caregiver. And then how can we bring that clinically into the room? Okay, I'm going to skip through the actual recommendations because I summarized them in this heuristic, but recommendations 1 through 6 are going to be shared with everyone after this talk. And they're, like I said, similar to what I just discussed in the summary. I want to wrap up with this with these next 2 slides that provide some clinical recommendations for actually providing the care. So the previous recommendations were for doing the risk assessment. After you've completed your risk assessment, how do you keep your families engaged in treatment, which, if you remember, is the very last step in accessing treatment. Number 1 is, how do you engage the family unit in all aspects of care? So it doesn't always have to be a caregiver. It could be an adult that is part of their life and is part of their family that can be a supportive adult in the context of their risk assessment. In some of our interventions that we provide in our clinic, what we do is we have the teen nominate 2 adults in their life that they feel that they can go to during moments of risk. Most of the times it's a parent and somebody else, like an aunt. A lot of these youth have nominated friends, they have nominated coaches from school. So we also integrate those, what we call caring adults or supportive adults, into the treatment. So think about, how can you enhance the teen support network by having them nominate and giving them the agency to nominate caring adults in their life. The second one, providing youth and family members with culturally relevant psychoeducation on risk factors associated with suicide. And spending some time to debunk some myths, which we are actually going to do with you in a little bit. And I oftentimes have like a 1-pager psychoeducation on risk factors that are culturally relevant. And it could be very validating to some of the families to hear how experiences of discrimination can impact their mental health. Reinforcing and praising help-seeking behavior is so important with the families that eventually make it into our care. And integrate a strength-based approach whenever possible. When providing lethal means counseling, tailor your psychoeducation around the different methods that are common for a group. Again, we're going to share in the link in the chat a link to a decision aid tool that is very helpful for clinicians. Disclosing your own intersectional identities with your clients, because you're disclosing or sharing with them your positionality. It could oftentimes lead to a stronger rapport building. And in the cases that I've used it, I have seen that it really does build rapport. And also, when you're providing skills for coping with stress, expand those skills to include ways of coping with environmental stressors. so community violence and racism. Okay, so I know I'm at time. Erin and Shabnam are now going to share some more specific strategies that you can integrate clinically. So I'm gonna move away to this one.
Hello, everybody. Thank you so much, Dr. Meza, for that incredibly informative discussion of different elements that folks can draw from in order to create and build a culturally responsive approach to suicide prevention and intervention. For the final part of this webinar, we really wanted to zoom into the New York City context and share about some of our experiences working with young people in group care in New York City. And by group care, we include child welfare, congregate care, juvenile justice, detention, placement, and residential treatment facilities across the 5 boroughs in New York City, working with ACS-run facilities as well as agencies that support group care in New York City. And one of the reasons why we wanted to make sure to have this discussion and to sort of challenge ourselves to think about generalizing some of the robust evidence-based approaches, Dr. Meza, that you shared with us that come from the literature, is because we know that sometimes outside of traditional one-on-one clinical settings, including in settings such as residential or group care, that it can be sometimes difficult to implement a treatment approach in its entirety. And also, that doesn't mean that there are not culturally responsive moments of awareness and action that can and should be at our fingertips in order for us to use directly and or for us to be able to provide as information for frontline or milieu staff, caseworkers, community outreach workers, as well as potentially for family members and folks in the broader kinship networks, Dr. Meza said that you highlighted, which could play such an important role in reducing barriers to treatment. And so that is part of the inspiration for us talking with you a little bit about some of our findings from recent surveys of young people in group care in New York City. And so, Erin, would you like to highlight some of those?
Yeah, so we thought it was really important to kind of situate also this conversation within the lived realities and experiences of young people. And here we are lucky enough to partner with and work with young people, as Dr. Dhavdani said, across multiple child welfare, residential treatment, and juvenile justice facilities. And our survey suggests that youth in NYC who are primarily youth of color are really at elevated risk for suicide. So these conversations are really important for them in our city right now. And we just wanted to motivate us all and highlight some of those. So in our study of over 100 young people across 30 facilities in New York City, almost half of all young people report having some thoughts of death and suicidal ideation, which is more elevated than the general population, as we know. Fully 1 in 5, 20%, have been hospitalized because they or someone else thought they might hurt themselves on purpose. And 16% sadly have tried already to take their own lives. And we're talking about young people who are 13, 14, 15, all the way up to 18. And 12% have thought just in the past month about how they might plan an attempt to take their own life. And 15% have thought about what to write in a suicide note in the last month. And these are very sobering statistics that are hard to hear and hard to respond to, but we thought it was really important to situate the situation within New York City and what's happening amongst our young people who are in our care. Go to the next slide, Jocelyn.
Thank you. Absolutely. And those statistics are primarily from 2023, so very recent statistics. We also wanted to underscore that the young people that we have worked with experience different manifestations of suicide, and we think that this is an issue of structural competency and cultural responsivity to note these. So on the left-hand column, you'll see that a statistic that we're reporting is that about 1 in 5 young people indicate a willingness to put their own life at risk without a specific suicidal ideation. So what does that mean? That means that these young people might not respond to assessments that are asking them, do you feel suicidal? Or do you think that you're going to self-harm? These are for better or for worse, more clinical terms that may or may not resonate with the lived experiences of young people. And yet we find that young people are reporting things like feeling like they might have a death wish, even if they might not say they're experiencing suicidal ideation, right? Or putting themselves in dangerous situations because they don't really care if they live or die. We know that sometimes these behavioral manifestations are thought of as antisocial or disruptive behavior, especially in clinical settings. But we make the argument that these are different ways that young people might be expressing distress that absolutely deserves and requires a safety enhancing response.
Yeah, and then it's also representative of their unique contexts and experiences and the exposure that they might have, as Dr. Meza pointed out earlier, to experiences of neighborhood violence or community violence. Another manifestation that we want to point out that we think is really important and increasingly important now is the increasing rates of overdose deaths due to fentanyl. We know and we have known for a long time that oftentimes young people and adults as well self-medicate in order to handle, mental health challenges that they might be facing without any sort of intent or wish to die. What's happening now with fentanyl increasing in the substance that are found readily on streets and available to young people, especially those who face structural marginalization, is that this oftentimes means that they're at elevated risk. The lethality of this is increased because of the circulation of fentanyl in our communities. And so what that means is that in our assessment processes, we also need to pay attention to that reality and think about these things not as separate dimensions or separate aspects of mental health experience, but really as co-occurring risk factors and co-occurring crises that we need to consider together. And so thinking about and asking about substance use and testing and increasing training for Narcan is really important aspects that we're seeing as beginning to implement in some of our work so that we can train frontline and milieu staff on how to administer naloxone or Narcan when they see signs of fentanyl or opioid overdoses.
Exactly. So when we think about the group care context or just non-traditional clinical context, we know that oftentimes there are some safety plans and protocols in place in a particular facility or residential setting. So upfront, absolutely, we want to underscore that it is important for staff to know what the safety plan is and how to access it, how old it is, whether and when to update that safety plan, et cetera. And to also understand that safety plans are primarily designed for crises and not necessarily prevention or early intervention, and certainly not necessarily for that incredibly important element of rapport building that Dr. Meza was underscoring for us earlier.
Mm-hmm.
Thank you.
So in light of that, we wanted to share a couple of steps and protocols and approaches that we are implementing in a study that we are conducting right now in partnership with ACS in these facilities that we referenced earlier. And this is in fact the study that the data that we talked about earlier is coming from. And so this project is an NIH-funded study called Safe Spaces, and its aim is to provide coaching and counseling to frontline milieu staff who are in these kinds of group care facilities, ultimately with the goal of reducing suicide and mental health challenges in both staff and youth. And so we're going to, in the next few slides, share some of the ways in which we talk to staff about thinking about suicide and assessing for suicide, and some of the ways in which anybody, not just a clinician, can engage with suicide prevention and discussions about suicide with young people in these settings, and can begin to work towards creating a more culturally adaptive and culturally relevant set of conversations around suicide for these young people. Go ahead. Thank you. Next slide.
Exactly. And on that point, the one lesson learned, one big lesson learned that we've had about this is that a 2-hour training that is content heavy delivered to staff may have its place at a particular moment in time, but that certain strategies like myth and fact busting that we're gonna show you a couple of examples of right now can be really important tools for staff, for supervisors, for leadership to be able to have at the ready in order to be able to support staff in facilitating, right? This could be, these myths or facts can be discussed at staff meetings. These myths or facts can be discussed as ways to engage families and surround young people with social support systems in ways that destigmatize the experiences that they might be having. So we have some examples of this for you.
So we'll ask you all to engage in the chat again and make sure you're chatting to everyone so that everyone can see what you're saying. And just ask you to put into the chat myth or fact. Asking someone about suicide will put the idea in their head. Immediately we have myths coming in. Amazing. Beautiful. All right. Nobody wants to say fact. And in fact, you're right not to. So we'll go to the next set. Yeah.
So absolutely, that is a myth. Talking about suicide indeed opens up channels of communication and the potential for support and resources. And this doesn't mean that these conversations around suicide or self-harm are easy or void of triggers. And it requires some practice, and it can require sensitivity in the ways that we frame and phrase and normalize these experiences for young people. Next one.
Okay, myth or fact? People usually decide to die by suicide for a long time before actually taking action. We got some myths, we got some facts, we got some facts, we got some myths. We're a little bit more mixed on this one. Okay, great. Why don't we go ahead and display our take?
Well, as you can see from the amount of words, this one is a little bit more complicated. So here's the myth part. In a study of people who survived suicide attempts, nearly a quarter said that there was less than 5 minutes between when they decided to attempt suicide and when they actually did. About half said less than 20 minutes, 71% said less than an hour, and the majority, 87%, said that less than a day passed between the time when they were thinking about attempting suicide and actually did it, right? So that window is actually short, especially for young people. And as folks are pointing out in the chat, they might be thinking about suicide and thoughts of death for a long time, but not be at a place of action just yet. And so this is a myth that it is a long time of planning, and we know that people experiencing these thoughts are often isolated. They feel like they might be burdens to their families, that they may have taxed their social supports and relationships. They might not have access to adults or peers for a long time before they're in a moment in which they have an actual acute plan. So crisis or imminent risk is often the culmination of many cumulative and contextual factors, which just underscores the earlier earlier points that Dr. Meza made about the importance of thinking about not just the individual, but the context surrounding individual young people, and increasing their supports and enhancing safety, even when young people are not at acute risk, is a really important moment of prevention and early intervention.
All right, last one that we have for you, myth or fact. Means reduction, and Dr. Meza talked about this already a little bit, minimizing someone's access to methods used to attempt suicide is an effective suicide prevention strategy. Truth and fact. Truth and fact coming in. Love it. All right, let's go ahead and display it.
Fact, absolutely. Means and knowledge of using those means impact how likely it is that a suicide attempt is lethal or ends in death. Determinants of the lethality of any given means include how deadly it is, how easy it is to use and access, the ability to stop midway, right? And the acceptability of that possibility to the attempter, right? And so these are types of things that to consider in order to understand lethality, that would be important in any kind of an assessment. But thinking about bringing a cultural context to this means learning about the types of ways that young people have potentially thought about or imagined dying by suicide if they have imagined it, as opposed to having assumptions about how that is typically done with young people. And restricting the means does not address the context of the individual or the lack of support that they are receiving. And so means restriction absolutely requires monitoring and follow-up.
Great. And so thank you all for engaging in that. We wanted to give you some examples of ways in which you can engage with the people that you work with, or check your own understanding in kind of an engaging way in order to really debunk some of the facts and myths around suicide. We also oftentimes with our staff and who work on our project, and also who interface with milieu staff and support families and support young people, provide them these safety enhancing principles to engaging in interaction with a young person around suicide, with the goal of really sort of trying to reverse some of the culturally relevant risk factors that Dr. Meza presented earlier, really thinking and taking seriously the fact that many young people, especially youth of color, do not have as much agency as they might want, as much freedom as they might want to navigate their lives. They're experiencing forms of marginalization and oppression that make these especially safety enhancing for them. So we encourage people to give youth as much choice as possible in terms of who they're talking to in a setting. So encouraging youth to have agency, allowing staff to give youth that agency to disclose and talk about these issues in the way that they feel comfortable in doing it, and in the setting that they feel comfortable in doing it. Keeping conversations as private and discreet as possible. Knowing the protocols of the settings that you're engaging with, so being responsible for knowing that, but also discussing how to strengthen those, and identifying gaps in implementation. So this is a great moment to start to integrate some of the principles that Dr. Meza discussed earlier, and really try to incorporate some cultural responsivity into some of the safety plans that currently exist. Remembering that these are difficult things and that you don't have to hold these alone or figure out what to do alone, and leaning on each other and talking about it openly in a way that still maintains confidentiality is really important for allowing you, staff, family members to be able to engage with this difficult content. We touched on this earlier, but destigmatizing, so using language that really destigmatizes and leads with empathy, acknowledging that these are normal thoughts and experiences to have, and removing blame and judgment is really powerful ways to interact and establish rapport with young people in ways that will help to destigmatize their experiences. And then just engaging from a place of trust. This goes along for me a lot with agency, believing in what young people are saying and not discounting their experiences, and also believing in your colleagues when they're bringing information to you. These topics are really difficult to talk about and worthy of attention if they're being raised and worthy of being taken seriously and in a way that allows for it to be disclosed in as safe and agentic a way as possible.
Absolutely. And we wanted to share two kind of tools, safety enhancing strategies that represent some sort of concrete, hopefully easily accessible tools that can be used for staff, for families, in order to support conversations that can be safety enhancing. So the first one is RAVE. And as Erin mentioned, we use this with our own team as well as trained staff, as well as support staff to use this, implement this with young people. And RAVE, is meant to support creating the context of dialogue and reflexivity that Dr. Meza started out talking about as a way to support meeting the young person where they're at, and as a way to support assessing and understanding what is important for young people. And so the four principles surrounding RAVE, the four strategies surrounding RAVE are reinforce any behavior that a young person might have taken to keep themselves safe. I'm so glad you called your friend when that happened. Express appreciation, even if you feel it, say it to young people, appreciate that they are safe and here with you. I'm really happy you're here. I got to meet you and talk to you now. Validate, reinforce the safety steps and structural supports that are used and reaffirm that they did the right thing. Reaching out to a friend can be so hard, but it's such a good strategy. I'm so proud of you for doing that. And empathize, validate and verbalize your validation about how scary or heavy that must have been, that must have felt. That sounds like a really hard thing to get through. Our experience has been that using these kinds of strategies supports young people feeling affirmed and being able to elaborate and creating the sort of conversational context so that you could follow up by asking about, for instance, experiences of discrimination or a context that are difficult to deal with, such as whether young people are engaging in risky behaviors in order to get access to food, material goods, money, and so on, which becomes so important as understanding their broader cultural context. Thank you. Great. And then another set of safety enhancing strategies that we use, we call PALS. And this is really for the specific moment of understanding the risk level that a young person might be in as part of or right before a safety planning actions that Dr. Meza talked about might occur. And so we know that when things are happening really fast in milieu or care settings, there may not be time for a full assessment, but we want to emphasize to staff to make sure that we are asking things about probability. How likely does it seem that a young person follows through on what they're indicating? Their access, does the participant have access to any method they plan to use? The lethality of the methods that are in the young person's plan, and the specificity of the participant's plan, so that when we hear something that is triggering and scary, we can think about these four elements and be sure that at a basic level, this becomes part of our assessment. And if it's not, to make sure that someone can speak with the young person further in order to assess these elements. Next slide, please. And we won't go through this in depth, but it will be in the slides for you. These are examples of things that would have constituted, in our experience, low and high probability access, lethality, and specificity. You can think about lethality, for example. At low lethality would be sort of taking 20 Tylenol. High lethality in a plan might be jumping in front of the subway. But there are no hard and fast rules to this, because if a young person said that they were going to take 250 Tylenol, that would be high lethality. And if they said they were going to jump from this building, and this building is 3 stories high, that would be low lethality. And so really bringing our critical thinking and meeting young person where they're at and trying to understand where they're coming from can really support understanding and really figuring out what kind of care they need access to in order to get the treatment and the response that they need and deserve. Thanks, Jocelyn.
And so just to wrap this part up, we have crafted 3 levels that guide our response to these kinds of experiences that we share both with our team and with staff, and for them to share with youth and with families. Level 1 is really assessing whether people have past attempts or past thoughts of suicide, and then your action step there, using the RAVE tools and the POWL tools, is to determine if these thoughts are current, to gauge the presence or severity of the past attempt and any current thoughts. And if there are current thoughts, then your next step is to then think about whether there's any current plan or any current means. So again, evaluating whether the plan is lethal or not, evaluating whether there's actual access to means or not. And then determining imminent risk if there are current plans or means, and soliciting immediate mental health or healthcare responses. And so this is just a rubric that we use to help kind of run through these experiences and think through them. And then, of course, for all of the responses, then our goal is to employ culturally responsive, evidence-based strategies that meet youth where they're at and really respond to the level of need that they have, given what they're experiencing and what they're voicing to us. All right. So we have, unfortunately, a shortened time this time for questions, but we do have a few minutes for them. So we'd love to invite you to put any questions that you want us to address, either in the Q&A section, or go ahead and add them to the chat if you're finding the Q&A section hard to navigate. And while you're thinking about that and adding that to the chat, please go ahead to the next slide. And we also want to invite you to fill out, as we normally do, a 2-minute survey, which will assess just your feedback on this. Thank you so much for putting your notes in the chat about liking the presentations and finding them useful. That means so much to us. We'd love you to fill this out as well if you can, so that we have it documented and we can tell everybody else how important this was and do things like this again in the future. Okay.
Yep, and finally, we want to, and then in the next slide, and we'll absolutely share out the slides, have a link for you in one of the slides, it's here somewhere, a set of resources with attention to the New York City context in particular.
It's one back.
One back, let's see.
Yeah.
Oh, no,
Oh,
it's not.
no, it's not there. All right, we'll make sure that it's in the materials. Was there? Keep going.
Yeah, absolutely. So we'll make sure that it's in the materials. You'll see it's a Google Doc that's open for everybody who has the link to view it. And you are absolutely welcome to distribute and use that set of resources, which is, of course, not exhaustive, but represents some go-to resources and a couple of highlighted readings, including a couple that Dr. Meza talked about today, so that there is a document that is relatively easy access to have at your fingertips, and hopefully also to add to as we continue this conversation and this work together as a community. So we really appreciate your engagement, and again, really appreciate taking that additional couple of minutes to complete the survey link, which we will link again in the chat. Thank you, Deja, for linking that again in the chat. And of course, you can scan the QR code as well.
Thank you, everyone, for joining us. Our emails will be available. Our links to our labs will be available in the slides that we will share, along with the resources that were just mentioned. We're getting a lot of love in the chat. Thank you, everyone, for taking your time to participate in this.
Thank you all. We appreciate you all so much and the really, really difficult work that you do and all that you bring to it. So we'll keep the conversation going.
Yes.
Okay.
Kelly, maybe we can stay together with Aaron and Shabnam for a little bit, and Kumar. I don't know if is that possible? I don't know if we can do that.
Yes. Aisha, did you, we see your hand raised? We see it not raised. No worries, that happens all the time. Great. Oh, thank you so much. So much love in the chat. Really appreciate it very much. Oh, no problem, Aisha. Wonderful.